from Stony Brook University. And our last panelist, who will be here shortly because Fordham graciously has two campuses, one in Manhattan and one in the Bronx. Yeah, I was like, that's the way the whole entire crowd was like, "Aw." So when Austin comes, just give him a big yeah, you're kind of tough welcome when he comes coming from the Bronx to here. But hopefully he'll be in time for the panel discussion. He's from Gramercy Surgery out in New York City. With that, I'd like to bring up Vice Dean Galen from Fordham University to give us some opening comments before we start today's session.
Okay. Good evening, everyone. I'm Ann Galen, and I serve, as we just heard, as Vice Dean for Graduate Education in Arts and Sciences here at Fordham. It is my privilege to welcome you, the healthcare leaders of New York community, to our Lincoln Center campus for cocktails with the Chiefs. I'm grateful for the opportunity to host individuals who carry such profound responsibility and such meaningful impact across the greater New York region. Now, I don't need to tell all of you that healthcare in New York is like anywhere else, is unlike anywhere else. It's fast moving, deeply complex, constantly evolving. In a single day, care teams across our city navigate everything from routine preventive care to the most advanced life-saving interventions. They do so across a broad variety of systems, major academic medical centers, community hospitals, long-term care facilities, outpatient networks, and public health organizations, all working to meet the needs of one of the most diverse populations in the world. The challenges of this sector are, again, I need not tell you, real and growing. Workforce shortages, rising costs, health inequities, behavioral health demands, the ongoing need to integrate new technologies from AI, which I spoke to a number of you about earlier, to telehealth, are reshaping what leadership in healthcare requires. Moreover, there is no margin for error in this business. People's lives are at stake. That said, the opportunity for innovation and impact has never been greater than it is today. The defining characteristic of healthcare in New York is not simply the scale of these challenges, but rather the caliber of the people addressing them. The city has long been known for leaders who are not just highly skilled, but deeply committed to service. Leaders who understand that healthcare is not simply a system, but a human promise, one that requires trust, empathy, and unwavering integrity. That's why associations like Healthcare Leaders of New York are so essential. Creating space for connection, mentorship, and the exchange of ideas is not a luxury in this field, it's a necessity. The future of healthcare will depend upon leaders such as you, those who can collaborate across disciplines, think beyond traditional boundaries, and guide their organizations through uncertainty with clarity and with purpose. At Fordham, we are proud to partner with HLNY in supporting that future. Through our healthcare-focused programs, including the Master of Science in Health Administration, we are helping to develop emerging leaders prepared to meet this moment. Individuals equipped not only with technical expertise, but with the ethical foundation and leadership perspective that the sector demands. That said, tonight is not just about one institution or one program. It is about the extraordinary healthcare community gathered here. It is about the collective leadership in the room and the impact you have every day on patients, families, and communities across New York. So I want to close in thanking you for the work that you do, for the leadership you provide, and for the example you set for the next generation. Thank you for the many lives that you care for each and every day, and for the wisdom and experience that you bring to this gathering. I hope you enjoy the evening and the conversations ahead. Thank you.
With that, I'd like to welcome Arthur Gianelli, President and Chief Transformation Officer of One Brooklyn Health, and also the Regent for HLNY.
Thank you. You all can hear me? All right. So, good evening. I'm a very proud member and have been for a long time of HLNY, and I'm a member of HLNY really for three reasons. You know, the first is that I think HLNY provides a forum, an opportunity for people all across our industry to come together. You know, so many of our meetings now are on Zoom. There's a level of impersonality to how we interact now that is different from the past. And I think the convening of people for a common purpose and for fellowship like we do here tonight, I think is a big deal. I think it matters to how we do our work and how we engage with each other and with the tasks before us. So collegiality and fellowship is number one. Number two, all right, is the opportunity to learn. And you're certainly going to do that here tonight with these really wonderful panelists. You know, the work we do as administrators of healthcare organizations requires constant education, all right? Constant testing of assumptions, constantly thinking and rethinking what we do and how we do it. We all face a number of the same common problems, all right? But we need to learn the best ways possible to make the differences in the lives of our patients and of our coworkers. And the third reason is it's an opportunity to give back. You know, I consider myself incredibly fortunate. All right, I've been able to build a pretty good career in healthcare administration, and I've done that not because I'm some genius, hardly. All right, but rather a combination of, I hope, some smarts combined with a lot of luck and a lot of good fortune and a lot of help along the way. All right. And I think that help along the way is really critical. You know, unfortunately, I think there are too many in our profession who, you know, rather than lend, you know, once they get up that ladder, rather than lend their hand down to help others, kind of kick the ladder out and, you know, just keep on moving ahead and not think about who's coming up behind them. And I don't think that's right. And I don't think we have the luxury to do that. I think we've all got to be committed to helping the next generation of aspiring healthcare administrators and professionals to succeed. This is a really difficult market. All right. It is very different, certainly, than when I started. All right. When I started, you know, having a career sort of based in hospitals felt like an incredible opportunity and also something that could really allow me to build a long tenure and a long career. Today, when I teach aspiring healthcare administrators, I tell them, as good as hospitals have been to me, I think you need to take a step back and look at the entire playing field, that there's other options for you. Because running hospitals is really hard. They're consolidating. The positions that used to exist don't necessarily exist anymore. Competition for positions is fierce, right? So that makes it even more important that those of us who have been fortunate, all right, recognize that good fortune was a key part in how we got where we got. And we got to go help those folks who are just starting out. All right, that's the objective, right? That's the commitment. That's the obligation, I think, of leadership. I think it's the obligation of success. Now, to that end, what my wife and I decided to do was to establish a scholarship. And we decided to establish the scholarship through the Foundation for the Healthcare Leaders of New York. And we were trying to figure out an approach, like, what did we want to fund? And I actually have to thank my good colleague and friend, Aliyah Ramjid. She came up with the idea that why don't you create a scholarship that will fund the tuition for a young professional aspiring to be a healthcare administrator to go to the annual Congress for the American College of Healthcare Executives. It's not cheap to go there. All right, between airfare and the tuition and everything else, that's not inexpensive, right? So I thought that was a really good idea, and it's the basis for the scholarship that we've established. I'm really proud that we did this. I'm really grateful that we had the means to do that. There's been 2 scholarship winners. I as part of the package, I spend about an hour and a half with the winner at the annual Congress, just talking about their career aspirations, their hopes and their dreams and their desires and how they want to shape their career. And I try to offer them something, just from my own background and, whatever quote unquote wisdom I can confer. All right. And in both instances, I've been really, really, really impressed with the awardees. So tonight's awardee, I'm trying to find her. Let's see. Oh, there you are. Okay. All right. Michelle Ayanyor. Am I pronouncing that correct? Michelle Ayanyor, right? So I got the opportunity to spend a good deal of time with Michelle at Congress. And as I said, really, really incredibly impressive. Her bio is in here. I'm not going to read it. I'm going to say a couple things. Point 1, what impressed me was at a relatively young age, just her grasp of the industry and the opportunities that were out there beyond, simply, hospitals, right? There's a whole world out there of possibilities for where you can impact the healthcare delivery system. So I was real impressed with that. The second thing I was really impressed with is the level of engagement. All right. I felt I was talking to a colleague that I had known for a long time. All right. So there was a level of familiarity in the conversation that I thought was, frankly, inspiring. And I think the third thing that I came away with, third insight that I came away with, is that the future's in pretty good hands. It doesn't always feel that way when we get up in the morning and we listen to the news and, we hear what's happening during the day, right? And, all of the challenges that we're facing at all sorts of different levels. It doesn't always feel that way, right? But I came away from our discussion feeling that way. All right. The future's in pretty good hands. Now, I still got a few years left to do what I'm doing, but it's important to know that as many of us move to the next stages of our careers, that the institutions that we've fought for, that we've struggled with, that we've committed ourselves to for all of these years, that these institutions are going to be guided by good and decent and intelligent people. And that is what Michelle is. So with no further ado, I want to bring up Michelle to receive her a certificate of recognition. Not to put you on a spot.
Sure, happy to. I'll keep it short. First and foremost, everything that I have done is by no strength of my own, certainly through God. I just want to thank Arthur, you and the selection committee for this opportunity to really empower me to be a lifelong learner. ACHE Congress was truly a treasure beyond price. And I want to echo some of the sentiments that you've shared in terms of it's important to rise. And I believe that we rise by lifting others. And so these type of opportunities are critical. I encourage you, if you have them, to propose them for early careerists, emerging careerists, et cetera. Thank you.
With that, Dr. Katz, panelists, the floor is yours.
Okay, great to see everybody, and I appreciate all the lifelong learners that are here, and I have special thanks to my own health and hospital crowd who came, and so great. So I appreciate it. I'm gonna ask each of the panelists, starting with Carol, to introduce themselves. And Carol, people, for everybody, they have your long bios. What I thought, especially from our earlier conversation, and I'll ask everybody else the same, talk about your first job in healthcare. And I'll be interested to hear what everybody's first job was.
Oh, I'd love to. My name is Carol Gomes. I'm currently the CEO at Stony Brook University Hospital as part of Stony Brook Medicine. And my first job, I was a laboratory technologist in chemistry department at one of our competitors now, but no. But I was there for about a year and then made my way over to Stony Brook and became a histotechnologist and really enjoy the biology and science of laboratory medicine. And so I was able to grow my career at Stony Brook. I'm really fortunate. I'm going on, believe it or not, my 41st year there. But I've had many different roles over the course of those decades, but laboratory science was my first love.
I love that, Carol. Gary, how did you start?
Yeah, hi, Gary Havican, Chief Operating Officer at Catholic Health, Long Island. I started actually as a volunteer EMT in high school. And then my first real paid job was a radiology transporter. And I'm still really good at the wheelchair and even better with the stretchers. So watch out. But my first clinical job, I was a paramedic. And I worked as a paramedic. Actually, I still am licensed. I worked for about 26 years until I became a hospital president, and that did that end. But yeah, so that's where I started, sir.
Okay, Austin.
Hi, everybody. I'm Austin Cheng. I'm the Chief Executive Officer of Gramercy Surgery Center. Just want to apologize for missing the cocktails part of Cocktails from Chief. Apparently there are, yes, thank you. Apparently there are two Fordham Gabelli buildings. The other one is in a different borough. Yes. So I'm actually a second generation surgery center owner operator. So I took over, I guess a bit of a cheat code, but took it over from my mother who founded the surgery center. We were really proud of her at the time. Very unusual founding, non-surgeon owned, individual who just applied for the license, called the CON, did the whole spiel in front of the Department of Health and got the license and kind of grew from there. So I actually grew up with the surgery center, sort of like in the family, started with paper charts, filing, all that, and kind of went up from there. So I took over after my mother unfortunately fell ill with a terminal cancer. So I sort of jumped a couple rungs, but that's how I am running the center today.
Nice. Well, so you don't feel bad about going to the wrong building. In my years in Los Angeles, especially if you wanted to go to Sacramento, there are two airports that you could easily go from. You could go from LAX or you could go from Bob Hope, and you just would make the decision based on connections. In my 8 years there, I twice, not once, but twice managed to go to the wrong airport. Right. And arrive at the airport and find out that no, actually your flight was from, and they're not near one another,
Were
right?
you,
Nothing in LA is near
Were
one
you a
another.
panel speaker when you got to the airport?
No, but both were very unhappy moments.
Yes.
So I've been, we're here, a bunch of people who are smart on finance, smart on healthcare. When I was a resident in medicine, so, now let's say 38 years ago, the GNP spend on healthcare was hovering about 9%. And my mentor was a major health policy person, and he explained all the reasons why that was not sustainable. You couldn't have such a large part of the country's gross national product be spent on healthcare. Well, he was clearly wrong that it was not sustainable because we're now above 18%. And so clearly that was wrong. And I guess my question, starting with you, Carol, is, so where are we now? Is it a problem that it's 18%? Would it be okay if it's 22% in, 5 years? Is this a real problem? Is it, not a problem?
Well, I think anyone who manages a healthcare organization today understands and recognizes that there are significant concerns with respect to financial sustainability, particularly if you're a safety net hospital, which Stony Brook is. We open our doors to all comers and we take all patients regardless of ability to pay. And we know, from a Medicaid standpoint that we're constantly in Albany advocating for Medicaid funding. We're constantly in DC advocating, and the costs continue to exponentially increase, whether it's chemotherapeutic agents and pharmaceuticals. The way that we deliver care, although we know that we try to be as efficient as possible, I do believe that we need to do something different in healthcare, whether it's modifying the way that we provide care and creating new care models, perhaps care models that we're not even aware of yet or that are in the process of being developed. But we certainly have to do something different than what we're doing now because it's just not working. And then don't get me started on insurance company denials.
Okay. What do you think? Is it sustainable?
Yeah, no, absolutely not.
Well, that's what they said 38 years ago. It's double Gary. I don't know.
I think it's, not only is the GDP component of it unsustainable, but what's unsustainable is the continuation of viable operations that generates enough margin to reinvest in the system so that we can continue to thrive as organizations. I think the statistic in New York is somewhere in the neighborhood of 75% of hospitals in the state are on that zero margin percentage area. And so we have a big issue. The costs of care continue to increase. The cost of providing care, doctors aren't making less money. Devices aren't getting cheaper. Pharmaceuticals aren't getting cheaper. And yet we're getting paid less, or at least the attempt is to pay us less. So it's kind of a quandary that we're in. And I don't want to pontificate on this, but I brought a little note here just to kind of share with everybody. We've been going through, we all go through the bond rating agencies, and we did a little bit of an analysis back a few years. We went back 5 years to look at our spend that wasn't there beyond 2023. So we said, all right, what are we spending now versus what we were spending in 2023? So that's, not that many years ago, right? 3. So inflation, when we took inflation, we looked at what we're spending now versus then, it's $185 million more per year. Increase in FTE post-COVID, as we had the great out-migration, we're spending $67 million more per year and 500 more FTEs than we had to backfill. I won't talk about HR1 because I think Dr. Katz is going to bring up HR1, but that's going to be significant as well. Anesthesia, subsidies that we're paying for anesthesia groups, subsidies we're paying for radiology groups, that's $30 million spent per year that we did not pay back in 2023. And the list goes on and on. GLP-1s killed us from a surgical perspective. The out-migration of, and I think clinically good, right? Good things happen. Good things happen that we moved the joint replacements, knee replacements and such to the outpatient environment and got those patients out of the hospital quickly. Fine. But that expense was about $30 million of our margin that moved out in the last 3 years. And the list goes on and on. So basically, the end result is we calculated that we are spending $443 million more on all of this that I just mentioned, and we weren't spending that 3.5 years ago. So that's unsustainable.
So Gary, I want to push you on this a little bit because I think it's really important for all of us to try to figure this out. It is undeniable that many hospitals are having trouble meeting the bottom line. That's not an issue. But reflected in the GNP is how much more we're all spending, right? And even in what the two of you have suggested, getting more money from the government or getting paid the correct amount, that only would push up the GNP. So maybe the question, and I'll start with Austin, is why does healthcare keep getting more expensive? I understand, and I think everybody in this room who's responsible for a budget understands what Gary is talking about. What Gary is talking about is it doesn't seem like the money the hospital is getting is currently enough to deliver what the hospital is delivering. But that's a separate issue than why is healthcare getting so expensive? And of course, part of why I raised the GNP is because that takes into account inflation, right? So it's a real apples to apples comparison. If we're spending twice as much as a percentage of GNP, we can't blame that on inflation, right? That's just how healthcare dollars are currently being spent in the U.S. So why are we spending so much on healthcare?
I think it's everything Gary just said. Costs to provide that healthcare are going up. So then the providers of healthcare say we need to negotiate for higher rates, and so it's kind of a tough cycle. I'd like to provide like a anecdote from not necessarily from my healthcare experience, but my experience running a business as a business owner. So in a sense, a purchaser, a large purchaser of healthcare. Our team is only 100, but if you take any company, Google, Home Depot, all these companies, they are very, very large purchasers of healthcare, right? So, I think it matters what they think and how they're going about their healthcare spend. But the first year that I took over the surgery center, we had I think it was like a 20% increase in our healthcare spend as like a company expense. So that's a very, large thing to occur to a company. One of your line items goes up 20%, the next year. And, so I started thinking like, okay, from the other side of the table as a, consumer of healthcare, this is not great. This is not sustainable. How do we drive that down as a company, right? And so I started to think, our surgery center itself actually is positioned pretty well to do this for the community as a whole. With something very, I say simple, but it's not so simple. The site of service shift from, let's say, a hospital setting to a lower cost surgery center setting, you can help drive down the cost of a surgical episode by like 50%. So we started thinking about that, the genesis being our own, experience as a purchaser of healthcare. And we thought, okay, why don't we present this solution to employers in the market? And so we've been helping certain employers drive down their healthcare costs just with surgical, episodes by going from a more expensive setting to a lower cost setting. And I think the companies now, the employers, are really thinking about what are like concrete examples, what are concrete initiatives that we can do to drive down the cost of our healthcare expenses. Surgery is just one, but there's pharmaceuticals, chronic disease management, all that stuff. So I think that's the key. And that's why I'm hopeful that although we have this skyrocketing health expense, it's eventually going to hopefully plateau and then go the other direction.
Well, I'm going to push you a little bit on that. First, of course, you realize you're going to make Doug's problem worse.
Yeah.
He's already upset because as you take the volume out of his hospitals, he still is going to have the same fixed expenses, right? All of us understand, how many of the taglines of healthcare that people think are wrong, right? Like my favorite tagline wrong is people say, "Oh, well, I kept someone out of your emergency department, so we saved you money." Like, you didn't save me any money. What money do you think you saved me? I run my emergency department with this number of nurses and this number of doctors, this amount of equipment. What money did you save me? It's a good question, right? But the thing that I want to push about, because I like the idea, and I think I think there are things that could be done less expensively. But I want to ask a global question. When I was a teenager, my parents were so proud that they got a Sony Triniton television, 19 inches. They paid $250, which was a lot of money then. Now I looked it up on Target. Now for $250, you can get like a 50-inch flat screen TV. Every homeless person we take care of almost has a smartphone. They may not have food, but they have a smartphone. Technology in those instances has made it possible for us to make things more accessible and less expensive. Right? That's how it works, right? Why is it that doesn't happen in healthcare? Why is it as healthcare gets more technologic? Because it's certainly way more technologic than it was when I was a resident. And I'm sure people who were practicing 75 years ago would point out how even less technological it was then. Why is it that healthcare seems to act differently than other markets?
I do believe, though, that the goal is to move toward different types of care models and provide care in a different way that is less expensive and more efficient, yet yields good outcomes, quality outcomes, safe outcomes. I know that years back, the promise of robotics and the use of robotic surgery, and I'm sure you use that in your ambulatory surgery center, reduces infections and reduces length of stay, and then reduces utilization in a hospital. That's just one example, in the past where.
But Carol, does it make healthcare cheaper?
Well, not if you have to buy the robot.
Exactly.
But over time, if you are using it regularly and you look at your return on investment and where your break even is and how many cases you need, and we've found that it has helped us, in terms of the types of robots that we're purchasing. We have joint robot and all types of robots. Whenever there's something shiny, a surgeon.
I think, Carol, I think where the research is on the robots is better outcome, shorter stay, less infection. Overall, you're not saving any money because the equipment costs currently offset anything. And then also to Gary's problem on one of the many sort of perversities of healthcare. If you provide less healthcare, sometimes in our system, you have less money, right? I posed to a hospital CEO, there's so much unnecessary MRIs and CTs being done. He said to me, "Yes, Mitch, you're right. But if we stop doing all those unnecessary CTs and MRIs, I wouldn't be able to keep the hospital open because I already bought the CT machine. I already bought the MRI machine, and I get paid for each of those studies, whether or not the person really needed it or not." So just to say how perverse the world in which we live in is.
It's true. But if you're managing an academic medical center and you're training up and coming surgeons, they're not going to want to come to work in your organization.
Totally true. Totally. But that, I guess what I'm saying is.
Going back to cost, you're talking about, the end game is reducing costs.
Well, I don't know whether I think I'm asking the three of you whether I began with the question. Maybe it's okay.
Question, Dr. Katz.
Maybe it's okay if in 5 or 10 years. Well, let's talk about for whom it might not be okay, right? So there are. You raised it. One issue is it might not be okay for businesses. because businesses are trying to provide health benefits. Healthcare goes up, your bottom line goes up. Who else is it not good for? It's not good if you're poor, because so people are watching what's going on in New York State with the essential plan, right? Okay, so because of HR1, which we agreed to talk a little bit about, there's no subsidy for those who are between 200 and 250% poverty. They can still buy insurance, still available on the marketplace. Insurance isn't going away. What's going away is the subsidy. Why do they need the subsidy? Of course, because healthcare insurance is so expensive. Why is insurance so expensive? Well, yes, there's some profit making this, but most, regulations, you can only spend 10% on your loss ratio. 90% of an insurance plan is the cost of the healthcare. So as healthcare gets more expensive, insurance gets more expensive. As insurance gets more expensive, if you're a low-income person without a job that provides you health insurance, you become uninsured, which then makes all of our bottom lines worse because we're taking care of more people who are uninsured. So that's certainly a second group of people who might care. I think part of the challenge is there's so many people who benefit from healthcare being more expensive.
Yeah, I think if you kind of think about the downward spiral, it can get very upsetting, so I try not to think about it like that. But it's very, it's true, if you don't think of concrete specific ways to sort of off ramp that spiral, we're going to spiral downward. So, that's why I spend a lot of my time thinking about ways that we can sort of help alleviate some of the, the pain associated with that. So, I gave an example earlier of shifting, higher cost surgeries to lower cost setting that might not be good for a hospital. So there are other things that we're working on. There are some health systems that have clogged ORs. They're unable to perform, the throughput that they want. And so they off-ramp some of their cases to us at a lower cost setting. That's not threatening to the hospital. In fact, they're asking for those cases to come to us. And I sort of ask why, because, you're giving up your, sense of your autonomy, having the patient, being performed at that hospital facility, you're giving up the facility fee. But if the hospitals don't do that, then, they may lose the patient because there's a long, waiting, time for that surgery. The hospitals are able to backfill or focus their ORs on higher reimbursing, higher acuity cases. So I think that there are very concrete examples on ways that we can gain efficiencies without being very downward spiral thinking.
Oh, sorry. Thank you. Well, let me, I'll pose it first to Gary. Gary, 15 years ago, there were no or rare urgent cares in New York City. Now, I keep meaning to ask ChatGPT how many there are. How many do you think there are? How many? You think 2,000? You think there are more than 2,000? You think 2,000 is the right number? This is every one medical,
it's every corner.
Every corner. Let's say, just for the sake of, it's 2,000. I recently looked at the data in New York State on emergency department use. New York State data shows that emergency department use is up. How do we explain, right, when I, as a primary care doctor, I was not very enthusiastic about these urgent cares. I'm like, urgent care is not primary care. People said, yes, but people can't see their primary care doctors. There aren't enough primary care doctors. They're busy seeing new patients. They don't see you when you're sick. You don't want people to go to the emergency department. So isn't this better? This is less expensive, so much less expensive. Okay, so now this real life experiment, something we didn't have 15 years ago. Now we have 2,000 of them. Why hasn't it lowered volume to emergency departments?
So let me start 15 years ago. I remember when urgent cares became a thing, and it was the 5 stages of PTSD for healthcare administrators, because we denied it. Says, no, that can't happen. Second is, Where are they going to go? The urgent cares, you don't need urgent cares. We're taking care of them in the ED. We're going to lose so much volume. We're going to lose so much reimbursement. It's going to kill us. Then when urgent care started to open up, it was like, okay, so you're taking our lower acuity and that's pretty good. We're opening up our fast tracks, our overhead, our fixed overhead costs go down because we can cancel off some of the nurses and the techs and the physicians that manages that area. And then we kind of embraced it. And it felt kind of good for a while. And the consultants came in and said, I know there's consultants in the group too. And they said, all right, when you're doing your MFP, Christine Flaherty, you know all about MFPs. When you're doing an MFP, you don't need an ED the same size as you used to, right? You don't need your inpatient volume the same size because you're managing the care in the urgent care setting, in the primary care setting. Things are moving towards, the ambulatory environment. We're going to quality as opposed to fee for service. All these things were coming into play over that time period. And things shifted. We have urgent cares on every block. It is the thing to do. We as consumers go to urgent cares. There's less out of pocket. You get directly into a health system. You get downstream referrals right out of the gate. It's a Class A facility. There's net promoter scores. You don't have to wait for a survey to come in the mail. All these things, they do it right. It's retail oriented. And so they're here to stay and we're all in the business of it. So the answer to your question is perhaps maybe the market just became so saturated that patients are attempting to go to urgent care, but they can't get in or they don't want to wait. So they continue to go to the emergency department. Otherwise, I think maybe that baby boomer curve is starting to increase the population that requires healthcare. And we're seeing more and more patients come into our emergency.
So I'm going to, by asking Carol, I'm going to sort of reveal at least what I think part of the answer is. Carol, do you think it's possible that demand for healthcare is unlimited? That there is no such thing? And I think each person here, one of the interesting things about healthcare discussions, I always feel, is that whether you're a smart healthcare executive like many of the people in this room, or you are a regular person who doesn't work in healthcare, you have healthcare experiences. You have your own, you likely have your parents, your children, your siblings, right? We're all at some point healthcare consumers, whether we mean for ourselves or our families. So is it possible that healthcare demand is endless?
It sure feels that way every single day. And I can say that because at Stony Brook, we actually were just listed in Becker's as one of the top 30 hospitals with the highest volume in the emergency department. I think it was at about 116,000 visits last year. But we also have urgent care and we also have telemedicine, and that volume has grown exponentially as well. And I think that the more we improve our access, the more likely people are willing to use it. And I do think, though, that we still have issues with access and particularly primary care. And, we were talking before about shifting a lot of the the main OR cases to ambulatory surgery to create more efficiencies and then backfill those ORs with more tertiary and quaternary care. I think it also goes to, we talked a little bit about health system integration and the fact that there are hospitals consolidating and forming, systems. And that hub and spoke model is really important too. Being able to maintain some of those higher level tertiary quaternary care cases in an academic medical center and then being able to partner with community hospitals to ensure that everybody's getting the right care in the right place at the right time. But I do believe that there is a concern around the access, and when there is access, people go for it.
Well, that's what I wonder is if you think about those urgent cares, you think about 15 years ago, let's say you have a sore throat and a cough. You think, well, I call my doctor. Well, my doctor's not available. I can't do that. I could go to the ED. No, I don't want to wait 8 hours. Oh, I can just go down the corner and be seen at the urgent care. Now, if that urgent care weren't available, maybe you would just wait a day. And the next day you might be a little bit better. My 22-year-old daughter, in what I felt was a typical New York City consumer experience, she's been getting into weightlifting, And she comes home from the gym and she said, Dad, I was doing some deadlifts and I hurt my wrist and the trainer said I should get an MRI. Like, sweetheart, you just hurt your wrist an hour ago. We are not getting an MRI. We can see how, but she didn't make up that the trainer said, right? And there are people in New York, right? So I'll ask Gary a corollary question because I'm sure he also, like me, has challenges hiring enough doctors. Do you have challenges hiring enough doctors?
Absolutely.
Is there a doctor shortage?
There is a doctor shortage.
How is it, though, we live in a metropolitan area that has a higher ratio of doctors per person than any other place on earth? How is it that we, who have more doctors than any other place on earth per person, how is it that we have a doctor shortage?
That's a huge question.
But there must be an answer
I
to
can't,
that.
I don't know. I can't. I think it depends on the discipline first. I think there's doctor shortages, certainly in radiology and certainly in other disciplines that are very difficult to recruit. Primary care is becoming one of those as well. But you're right. I mean, we have a significant population density, so perhaps the ratio of physicians to patients is not where it needs to be. But I think we're suffering from the same woes as everyone else across the country, regardless of our geographic location.
Well, at the risk of offending my profession, do you want to rule out the possibility that the more doctors you have, the more doctors you need? You want to rule that out? It's the corollary to my question to Carol is the demand for healthcare perhaps endless? And I'm trying to not put any value judgment on that thing. Maybe it's a good thing, but it's hard to get around the possibility, right? If we feel that there are not enough doctors, how do you think they feel in Louisiana, right? Or in other parts of the world, right? And I have to say, right, there's another thing that I found interesting. You know, there's been a lot of concern about the impact of the visa requirements on the ability to recruit doctors. And the only thing I can say about it is, but the places that we're recruiting from have way fewer doctors than we do. So, I mean, I am against the visa demands because I believe in free immigration and that's what makes this country great. But putting that aside, it is a little funny to be working in a metropolitan area with the highest concentration of doctors of any place on earth.
But I
And
think-
people feeling there aren't enough doctors.
I do think, though, Gary, the point that you were making with respect to the subspecialties of those shortages, particularly radiology, pathology, it negatively impacts the care that we're providing because you need those subspecialties in order to diagnose and treat disease. And if you have a shortage of those particular physicians, you're, at a loss.
I think part of it too is we're putting more administrative burdens on the doctors and providers. So the time is not spent, 100% providing healthcare. I think everybody understands there's this big administrative, burden or waste. So, maybe perhaps part of the solution is, if you can't grow the doctors, maybe cut some of this administrative burden that they have to deal with and allow them to provide care to more folks.
Well, I think the doctors would certainly welcome that. But I don't, let me just say it in a different way again. And this is as a primary care doctor, this is something we deal with all the time. In other places, you don't have to worry about whether or not you have an MFM, maternal fetal medicine doctor, for those of you who don't follow. I have a terrible shortage of them. There are none in Montana. The OBs just deliver the babies, or it turns out that the family practice doctor delivers the babies. And everybody accepts that because, maybe if you wanted something different, you would drive 300 miles. And people, don't want to drive 300 miles. We are in this very interesting metro world where, in a sense, you can get every specialty, theoretically, assuming you're well insured.
We have
Um,
EICUs and all types of technology that can help us with that.
Right. But it is possible that the more you have, the more people want. And again, without any value judgment on whether that's good or bad. I mean, I would certainly prefer that our government spends money on healthcare than, say, making wars. You know, so if you ask me, you want to spend more money, Mitch, you know, it's your taxpayer money, more on healthcare, more on, you know, missiles. I'll go for the healthcare. Now, do I feel the same way about healthcare education? Not sure. Do I feel that would I prefer my government to spend more money on healthcare or more money on education? Complicated question. Would you rather, Carol, more money on healthcare, more money on education?
I think you need both.
But you have to, I've just appropriated a new 100 million. How do you want to spend it?
Carol, how about healthcare education?
Well, of course, I mean, when we talk about going into the community and focusing on access, it's really important to ensure that we're providing that education for the community and ensuring that they understand when they need healthcare, providing screening, making sure that they're educated in terms of chronic disease, acute disease, and all of the above. I would, of course, support healthcare education in the community. And, you know, that's certainly what we attempt to do when we have our mobile units. We have mobile stroke units. We have mobile mammography units. We have mobile dental clinics. And we're continually educating the community, going into barbershops, going into churches and areas of worship and community centers to ensure that we give as much education as we can to our community. And it can only do good.
That's great. Carol, while you have the mic, talk a little bit about some of the sustainability efforts that you're engaged in and why you think they're so important.
Well, thank you for asking about that. Sustainability, environmental sustainability is so important to us. Back about 15 years ago, when I first became Chief Operating Officer, we were focusing on becoming a mercury-free hospital. For those of you who may remember, there were thermometers that had mercury in them. And so back then, that was the first initiative where we became a mercury-free hospital. And it really just kicked off enthusiasm and passion from our team to want to continue to support environmental efforts. And there's an organization called Practice Green Health. I'm not sure if any of you are familiar with it, but it focuses on green, sustainable activities, particularly for healthcare. And so what we did was we organized Stony Brook Medicine to support various subcommittees of a large steering committee that focuses on energy, utilization, waste associated with recycling and so on, medical regulated waste. We focus on food pharmacy and creating a sustainable food environment. We have a rooftop garden, and we actually use and harvest that garden for food to feed our patients and also our community for patients who opt in with a social determinant of health with food insecurity. We also focus on leadership and ensuring that we provide all of the resources that we need to be able to support environmental sustainability, including healthy interiors and green buildings. So really a concerted effort, and it really comes from the bottom up with passionate staff members and physicians who wish to partake in all of these activities. As a result, we've significantly reduced our carbon footprint. We continue to do that in various ways. And we were named one of the top 25 hospitals in the country for environmental sustainability, not only overall, but also for energy, chemical safety, and leadership. So we focus on reducing the use of hazardous chemicals in the laboratory, which again is near and dear to my heart, reducing the use of xylene and histology and formaldehyde. And it's just really made a tremendous difference in the morale of our team.
That's wonderful. Gary, adjacent to some of the things Carol talked about, the role of a hospital system like yours in addressing social determinants.
Yeah, I mean, it's part of our fabric. It's part of what we do. Obviously there are major opportunities for increasing access to care, to reducing any burden or barriers to get into see specific specialties. We too have mobile response units that go out into the community to provide pro bono, medicine and treatment. But access is key, and social determinants of health is something that we bake into everything that we do. It's a very important piece of the work that we do. As a matter of fact, one thing we're working on right now is to increase the access of hereditary risk assessment into communities that fall into the social determinants of health kind of bucket of reduced access. And so identifying through a genetic test whether or not somebody has a predisposition to getting cancer is a way we could start the preventative world in that community. And so we're doing a lot of work around that in particular, but it is certainly something that's baked into our operating model and how we do business.
That's great. So we're going to do the last round of questions. Really, I've learned a lot just listening to the three of you. Austin, I'm going to start with you. Obviously, right now, AI is a very hot topic on how to best use AI within healthcare. And I'm wondering sort of what you see as now or future uses of AI, within your surgical centers, or how you see AI changing the general delivery of healthcare.
Yeah, I think this is a hot topic. I think you see a lot of companies even outside of healthcare looking at, AI strategy. How do they, maximize this technology to improve, either their delivery of service, their product, their bottom line. For us, the surgery center world is interesting. I feel like a lot of the technology gets, pitched to the hospitals, becomes really integrated with the health systems, and then it sort of trickles, down into the outpatient surgery center world. So we're, as an organization, we're not in a rush. What we would hate to do, we just had this discussion the other week, actually, we would hate to have like 10 different point solutions for each like workflow and then have 10 different AI vendors. So, we're taking our time assessing, what the best place is. Hopefully there's one vendor that can just kind of do it all. That would be great. Right. So, I think what we've seen is a lot of the technology is pointed to areas with a very easy to explain ROI. When you're, not to make it all about the business and the dollars, but when you're pitching, I'm sure a health system, you have to make sure there's the ROI. So I think a lot of the technology is focused on that. You see a lot of rev cycle, AI. And then I think you see the other side of the technology where you're able to lay it over, providing clinical services. And I think that part is really interesting. I think that there's some long-term, we got to look at that for long-term. Maybe that's a solution for shortages. I'm a lawyer by background. So another part of me is thinking like we have to be, sort of cognizant of the, the risks, the legal risks involved with, certain technology. So I don't know. We'll see. Excited to see how it all pans out. I'm waiting for the hospital systems to make a decision first, and then I'll just do that.
Well, no pressure, Gary. But while you're thinking, I'll tell you my favorite fantasy use of AI is for prior authorization. And what I most wish, you have to hear the whole wish, is for the bots to be arguing. See, what I most want is I want that MRI approved. No, there's no way I'm going to approve it. Yes, you see that person has the indication. No, I don't see it in the documentation. And I just like to imagine a world where these bots are arguing. Is it already happening?
It's already happening.
I like the idea of no humans are involved, and that that the bots might just endlessly fight about whether or not to approve the procedure.
No,
Oh.
it is happening.
Okay, Gary, what do you say?
I think that's bittersweet. I mean, the insurance companies did go with AI to actually do, rejections and denials on our claims. And now we have to have an AI bot that works our claims and enhances CDI. And we have AI that's layered all within our EMR to increase our coding, our documentation, our billing. And that's the reality of our world that we're in today. But AI is actually, if you choose it correctly, and I understand the legal ramifications, so you have to really have time to do your due diligence. But we're doing some cool work. I mean, every one of our vendors has AI, right? Our technology vendors, it's AI that's all layered in, and it's wonderful. And everybody's using it a different way to really increase and optimize healthcare delivery. But what we're doing, we're using now ambient voice AI, which is a very cool feature where our physicians, when they're interviewing patients, they just speak and they open up an app in their phone, and that app in their phone takes everything down and puts it into a format that is in the EMR, so they don't have to separately chart, and they're in the patient's face talking to the patient, so the computer screen is not in the way anymore. We're starting that on the nursing units as well, so the nurses have more times with their patients, and they don't have the big cow or wow, whatever we want to call it, in front of their face either, right? So I think we're really looking at AI to be complementary to the work that we do to reduce that burden that I guess some folks call it pajama time and other burdens. We want to make it work for the individual organization and really optimal work that's happening. But we're certainly seeing in our radiology space, our lab space, digital pathology, AI layers on that. So it is very much a part of the business that we do, and it is rapidly evolving. Like the things I just mentioned, really in the last 18 months, they've really gotten a lot of traction. So we're at the very beginning of what I think is going to be a huge endemic of AI-related issues.
I know we talked a little bit about ROI with AI, and I think that the pajama time is a real thing.
Yes.
And it also prevents physician burnout and other, nurses now we're looking into using ambient listening for nursing documentation as well. But it certainly does improve for clinical documentation, revenue cycle, and all of those that administrative burden. But there is something to be said for the pajama time, which really there isn't much of an ROI on. But if you can maintain physicians and have them stay in your system because they know that you're taking the time to recognize their value, it makes a big difference. And then they can spend time with their families at night.
Be interesting to see how that works. I was imagining myself during again the time of my career. I remember as a healthcare administrator when it was important to me that the mail came. I don't get anything in the mail. Maybe I get the occasional anonymous letter complaining about someone comes to me in the mail. Pretty much I get no mail anymore, right? I am, have been doing this long enough to have done it before email, right? And certainly before clinical charts, right? So all of these time-saving efficiencies have occurred under my career, right? The only thing is that now I'm always working. I didn't used to always work because I didn't used to have even at first, of course, there wasn't email. But then when there was email, I had to go to my office to get it. Now I can happily get and answer my email all of the time. I also happily now can get requests from my patients all of the time because I have a HLNY app on my phone. So my phone blinks every time a patient sends in a request for medication. So what I think is somewhat interesting, and again, that's why I'm always interested in how technology plays out, all of these time-saving things, and I would also say, and many of the administrators in the room would know this, many of the projects that all of you do every day, 35 years ago, if someone had asked me for that report, I would have said, that's impossible. Or maybe it would take me 6 months to do it, right? Okay, well, I'll, go hand review those charts, I guess. So there is the problem that as the technology allows you to be so much more efficient, it could be that everybody's expectations of us just grow, right? And I think many of my patients would be upset if I didn't answer them today, right? Because they know they sent me the email or the text or that they put it in today. And so I think it's sort of an interesting question of as technology makes us more efficient, does it also sometimes make us just work more? And what is the implication of that? So with that, I want to thank my three great panelists. Thank all of you for listening. Okay, great.
So you said before, you questioned before whether there's an unlimited demand for healthcare. And towards the tail end of your presentation, yes, as the technology grows, and I think as we, as consumers, right, in this world we live in, where we just click and swipe and magically there's a package on our front porch in hours now, what used to be, wait 2 days. And I think that's part of the problem. It's us and our expectations that everything is always available all the time and at the highest level possible. So I agree.
If you think about the patient portal, now the results are immediately on the portal, and many times the patient will see it before the physician sees it. And so again, it sets that level of expectation. Yes.
Go
I think
ahead.
Carol mentioned access earlier too, and the consumer expectation, all of us here, is that there's immediacy, right? And so those that master access get the volume. And so it really is an access game for a lot of us in the healthcare industry. It's seeing how we can do things better, how can we be open more often, and how easily accessible we can be. And using AI and now bots to respond to your text message at 3:00 in the morning about your appointment is becoming commonplace. So I think that is another layer of access.
Hi, my name is Dan Pitkinson. I'm President and CEO of Ryan Health, which is a community health center, federally qualified health center in Manhattan. Community health centers in New York State serve 1 in 8 members in our state. We have better outcomes, and we do it much, much cheaper than many, many other health systems. There's only about 7 or 8 cents per dollar spent on primary care and prevention out of every health dollar. So when you talked about GDP and the amount of money, and it's interesting to me that there's not a primary care provider on the panel.
Me.
I knew you are, but you're also the moderator. So is that if we shifted some of those dollars, and I'm sorry, away from hospitals and away from surge centers and into, and I appreciate that you have mobile units that go out, but if you actually moved some of those dollars into community health centers like Ryan, like Gotham, like many others, is that we wouldn't need a lot of people out in this room. And is that better for society? Do we need, I mean, yes, it's great that we have jobs, but don't we want healthier citizens who don't need surge centers, who don't need things you mentioned, biochemotherapy that I don't know on West 97th Street, and my patients will never get because Mount Sinai or the other places don't want them. I'm just picking on Mount Sinai. But, you know, we love Harlem Hospital because they're open their doors. But 8 cents on the healthcare dollar to primary care? Like, why? Like, so when you talk about it, the money needs to be shifted. That's my answer.
I think it always comes down to right patient, right place, right time, and right care. And I'm not suggesting that, every patient should come to an academic medical center to receive primary care. And in fact, we're really working toward building our primary care structure. In fact, when we didn't really talk about service line growth and financial sustainability, but as part of our service line growth, the primary care docs in our organization said, well, it's really important that you grow our business because we're the, first defense there. So that is exactly what we're doing. And so we're building a lot of advanced specialty care centers, but there are built-in primary care docs in all of those new centers that we're building. And so we recognize how important primary care is.
I think it's really important to partner with FQHCs. I think, you can't be all things to all people. And we can't be all things to all people. So partnership with FQICs, plus you enjoy a different reimbursement structure from a Medicaid perspective that we don't. And so I think that partnership really makes good sense. And we can't be in every community. And so I think, a health system would be blinded not to work directly with the FQHCs in the community. So just to respond to that.
Yeah, I agree.
And I think, something that, just to kind of hark back to earlier, I think the folks who control the spend are really going to start to feel the squeeze, if healthcare costs keep rising and rising. And I think that's why I mentioned the employers. When you look at America as a country, I think it's going to be the employers that look at their healthcare spend and make a shift in our industry, because they're going to say, this is just not sustainable. And I think that's where it's going to be coming from. I would love to have more, sense spent on, preventative care, and hopefully they can avoid, surgeries. There are some surgeries that are not avoidable, and that's where we would come in. But I really think the employers are going to shift the way that healthcare is, received in the country.
Okay, I think that's our question. Who has the mic here? Oh, go ahead.
Hi, you guys hear me okay?
Yeah, go ahead.
Hi, Domenico Rossini, Mount Sinai, South Nassau. So I wanted to go back on the point you made about unlimited demand. So do you think that has to do with like the aging population, right? Like our baby boomer generation, like getting older? And do you think like 10 to 15 years with like our population like expected to shrink, do you think like we're kind of like gonna level out in our spending at least?
So different people can have different views. I don't believe that the demand is because of the aging population, because while there's some demographic shifts, older people are also much healthier than they once were, mostly because of less smoking. So in general, older people have much more vital lives. I do believe it's a demand problem for the reasons people have raised. Access, right? If it's easy to get. Community standard, which relates to what you said about FQHC. So as a primary care doctor, you come to me with crampy abdominal pain. Chances are you're going to get an exam and reassurance, unless you're telling me that there's blood coming out the other end. If you go with the same crampy abdominal pain to any emergency room, including mine, you're going to get a CT scan of the abdomen, because that has become the community standard. And doctors will not, nor can they really operate outside of the community standard. So once you establish a community standard, and we in New York City, in part because we have a lot of doctors and a lot of specialists, there's a lot of money to be made, both by systems and those doctors, it becomes the community standard. And once it becomes the community standard, it's very hard to fight it. And so when they go to a great FQHC or they see a good primary care doctor, they're likely to be reassured unless there is some danger sign. We know our patients, and so we have a different view of them. And I think that's part of what people would say about the community standard is your providers know the patients. And so they feel comfortable sending them home without the CT scan. But we in the emergency department, we don't know them. We've just met them. And so at least my view would be that that there is a degree to which the more doctors you have, the more doctors you'll need. The more systems you have, the more systems you need. The more you improve access, the more demand. And all of this may be good. But it's expensive. And people have to decide whether or not, as a society, they're good about spending this amount of money or they're not good about spending the amount of money.
Thank you all for your comments today, by the way. So I was reading an article in Becker's about Mark Cuban's new payer, we're going to call it a payer model, direct contracting here, making a somewhat big splash in Dallas, Fort Worth, Baylor, Scott, and White. What do you think about that as potential disruptor? Carol, not to use a trigger word for you on insurance companies, but what do you think about that as a potential disruptor here? What do you think that's going to potentially look like if he's successful with rolling that out?
I'm not either.
I'm happy to speak to that. We're doing that a little bit. So the model is direct to employer. So some employers are becoming smart and asking the questions, why is our healthcare expenditure, going up and up and up? What can we do to avoid that? So one model has become that the employers contract directly with the providers. And then the employers pay the providers directly. They cut out the insurance company. There's a level of savings there. I think the trick about that is if you're an employer, you need to have an adequate network of providers to supply your employees. If you tell your employee, like, you can get your healthcare at like this one doctor, they're going to say, what the heck are you talking about, right? So I think there's a level of growth that you have to build an adequate network for the employer, and then you have to. I think there's, you have to hit the. It's not just like geographic coverage, but also everything that the employer would need or the employees would need to receive that health care. But I think this is. I think it's a wave that's going to come through the healthcare industry. It's not just so we see it obviously from the surgical side, but we see it again from other areas. There are PCP models that a group provides a PCP to a company, an employer, and they do like some type of like per member per month fee, and there's no charge for the healthcare. It's just this like primary care provider whose job it is to provide care to that employer and drive down the cost of their care over time. But yeah, I really like solutions like that because I think it's about driving the cost of care down, so long as you don't sacrifice the quality of care.
There are two thoughts. First, unions, many have done this, right, where they're taking the risk, but they're paying just direct, and you save 10%, right? Because that would be an average cost for the insurance company. One proposal that is in some ways similar, which I think would have been one of the successful solutions for the U.S. that was rejected, was simply do Medicare for all. Medicare is a fairly popular program, right? You can't say that it's socialism. You can't say that it doesn't work because it covers everybody in our country who's over 65. Runs on a 4% admin cost. So unlike Medicare Advantage, which runs at 10% or more, 4%, you can see whoever you want. Just about every provider takes Medicare. You would then not have any separate insurance forms. You would have no separate prior authorizations. You would have no specific formularies that you'd have to follow. We would all be covered in the same way. Not a government-run system, Medicare, in the sense that you choose your own doctor, health center, hospitals, all your own choice. But there's one payer, one rate. Hospitals would fight it like crazy because the private insurers pay more than Medicare. Private insurers would fight it like crazy because they would go out of business. Device companies, pharmaceutical companies would fight it like crazy because it'd be harder to justify their rates. But it would serve the purpose, which would be to drive down the cost of healthcare while equalizing access to everyone. A very different proposal, if you want to think about these proposals, are only worth thinking. They're not going to happen. They're only worth thinking about because what they tell you is wrong with your current system. When you talk about direct care, what I remember is when my mom would take me to the pediatrician. At the end, she'd say, "How much is that?" And he'd say $20. And she'd give him $20. And that was how it was done, right? There was no forms, right? There's no insurance. And while you might say that's antiquated, well, actually, I would be okay without insurance if you gave me catastrophic insurance, right? If you just said to me, Mitch, as I'd say, I want to be covered if I got AML, if I got leukemia, right? Because I couldn't afford to take care of myself if I or my family. But why is it that I'm having insurance to pay for my doctor's visit? I could pay for my doctor's visit. And if I paid for my doctor's visit as an employed person instead of my employer giving me insurance, it could all cost so much less because the doctor wouldn't have to fill out any forms. right? And I could comparison shop because it'd be my money. So I can also imagine, at least theoretically, a system where everybody poor who can't afford to pay, they get Medicaid, right? But the rest of the people who have employment-based insurance or market-based insurance go to some kind of program whereby we're covered if something disastrous happens, like with car insurance, right? You use your car insurance or your house insurance when something huge happens, right? You don't need it for, a $50 ding on your bumper. But we have made insurance the method for everybody to get health care. And it's not clear to me that that's such a great method because it sure drives up the cost. And the direct care is one attempt to get away. It's from the idea that I, as a doctor, in order to get paid to see you, I have to fill out a form, or at least I have to have somebody fill out a form, and I have to send it. And if she has a different health plan, I have to send a different form to somebody else, which has different codes. And so then I have a whole staff and a whole administration and a whole computer thing that it's all about people paying us for things that they could much more easily just pay us for, right? And then they could comparison shop, right? The people thought that there would be a lot of value from getting people to comparison shop. And you know this in your surgery center. If you're charging less than Gary is, but I pay the same copay, what do I care?
Mhm.
You want me to go to you because it's less expensive? And even if you tier the copay, okay, it's $20 for you and $40 for Gary. Do you think that's going to be material to me on where I get my care? But if I had to pay out of pocket, then it would be very material to me. I think someone up there had a question.
Yeah. Is this working? Yeah, I have a question. I come at this from a perspective of the real estate world because I run a healthcare real estate brokerage. We're talking about access, we're talking about a room full of administrators. We're talking about competition with physicians. I wonder just, with the panel that we have, from that perspective, how do you think about trying to solve some of those issues, trying to retain talent and, give the best care and also provide the best access? Are you thinking often about it from the real estate perspective? And if so, how are you trying to solve for it at your respective organizations?
So, yeah, I mean, we had this conversation like 4 hours ago. We not unlike many other health systems over the last 20 years have been acquiring physicians. And part of that business is you acquire typically their practice in the real estate that they either own and or are embedded in. And then you end up at the end of the day with, 122 different sites across 3 counties. And, each one of them has a different class. And each one of them, some of the sites, it was a mom and pop shop, literally. You had the manager was a relative, the dog was in the practice, and that's what you got because that's what you wanted and that's what you needed. But now, just from a real estate perspective, answering the call of the public and the access component of it, it's the big box is in. The big box is better. The one-stop shop for accessing your physician, your imaging, your pharmacy, your downstream referrals is the way to go. And so I think, and I know what Stony Brook's doing and they know what we're doing because we're in the same markets, but we're consolidating a lot of these one-timers that, we're in play forever, and we're consolidating them into the big box concept so that it's much more consumer driven and accessible. So that's where real estate really comes into play. It's getting away from the smaller and getting into the larger, but in a population dense location that's easily accessible, both egress and access out of it. So it's a big conversation constantly in our space.
And you're absolutely right. That is precisely what we're doing. We had over 200 sites. We call them onesies and twosies, just, small group practices that we had acquired. And it really doesn't make sense to maintain all of that real estate. So as a result, we're consolidating into what we call advanced specialty care centers, where we have multiple disciplines housed under one roof. And it's more convenient for patients because they're able to see their primary care doc, and then there's a subspecialty that they need to see, perhaps an endocrinologist. Well, right down the hall, we can get you an appointment in an hour. And it's just, it's been really helpful for us to be able to consolidate the leases and then to strategically locate them in areas where there's need.
We share one at Comax, so I open up doors
Yes.
from her place to mine. I said, come on in here.
Then I say, no, come here.
Yeah, so we don't have that much of a footprint. We're 2 facilities, 2 additional admin offices, but we have a management development arm where we help others stand up surgery centers. So we've seen like a kind of like a medical mall model that Gary was talking about. It makes a lot of sense. I think why that would make me nervous though is when you look at like I guess from the population health perspective, like you have to make sure that there's adequate like access points for the patients, right? So if you have a singular point of care and it's at a place that's difficult for this community to reach, then I think from a community perspective that becomes a problem. But but there are efficiencies. I think a lot to be had in something like that. Yeah.
I think, a lot of the malls that are vacated, they're empty. That's, what Stony Brook did. We used a Sears space that had closed, and it was part of Smith Haven Mall, which is out on Long Island. And what's great about that is there's access to bus routes. So for patients who don't have transportation, they can take a bus and it's easier access. And for us, that was one of the social determinants of health that we focus upon is transportation.
That's great. Okay.
Hi. First of all, thank you for taking the time to speak with us today. I'm Jamie Rose Zappolo. I'm a health administrator in College Health, a retired tissue recovery specialist, and current MSHA student. And we've seen that population health is really important, especially since 2020. So when you guys have the conversation about whether we put funds towards healthcare or towards healthcare education, choosing healthcare education aside from mobile clinics and community tabling events and brochures, for funding healthcare education, do you mean maybe funding some future medical students who maybe aren't at the top of their class but show really promising, basically show passion for wanting to be a doctor? Or are we talking about educating maybe health literacy from middle school to high school? Because I'm in College Health, I see a lot of struggling student patients who don't really understand a lot in healthcare when they are seen for an appointment, and we're seeing more students being diagnosed younger and younger with some health conditions that will lead them into the rest of their lives, even cancer. So I was just kind of wondering more about what type of health education you would be interested in funding.
Health education, what do you think the greatest priorities are?
Well, I mentioned before, in terms of the community, I think it's really important to go out and educate within the community. But we also have programs for high school students and middle school students, and developing workforce pipelines to teach them about the health professions and to have them educate people within their own community. So it's really kind of a pay it forward. A lot of our medical students at Stony Brook actually participate in a lot of our community efforts in our community. I know you mentioned tabling, but we also have a medical clinic for our residents. It's called Black Men in White Coats, and they are out in the community in barbershops, and they're educating the community and talking about what's important in terms of healthcare and promoting wellness. And I think that that's really important.
They're a great group, Carol.
They are.
People are starting to leave, I'm noticing, and
Yeah.
we're getting late in the hour. So I'm gonna call us a night, and again want to thank the amazing panelists.
Thank you so much. Thank you so much. We love this panel so much. My name is Gina Velzen. I am the president-elect of HLNY. I'll just keep you for a couple more minutes longer. Please, panelists, stay. We'll take a photo on the
Yes.
stage after. I just wanted to give some closing remarks. If you hadn't seen the QR code, I'm gonna, spoiler alert, flash 5 QR codes. So just keep your phones up like you're taking pictures of me, that's fine. And make sure to capture these. We have changed our ACHE sign-in for credited events. So if you want your 1.5 in-person credits today, make sure that you've scanned that QR code by the end of the night. It's also on the back of your name badges. Program's very clever, so you can take that with you. Our second QR code, we have our evaluation link. So if you did like this panel, please share what you liked about it by following this QR link. And if you didn't like it, you can send Dr. Katz some snail mail with those complaints.
Please do.
He's open to that. But in all seriousness, this was a very insightful panel. We appreciated hearing how each of you are leading your respective organizations with bravery and against the downward spiral of the healthcare environment. But you painted a really optimistic future vision of, AI bots fighting prior authorization battles to the death on our behalf. So the future is bright and we're looking forward to that. We want to thank all of our many sponsors, many of you who are in the room. Thank you so much. All of you help provide the wonderful educational panels that we can put on, all of our events. And really, we truly consider you all actually our partners in this. A good example of that is Fordham University, one of our silver sponsors. We thank them for this wonderful venue, for hosting us for this session. If any of you are, thank you, round of applause. If any of you are interested to be a sponsor from your organizations, my organization is a silver sponsor as well. You can email sponsors at HLNY. Carla and Jonathan would be happy to hear from you. Upcoming events, you also have it on the back of your leaflet. We have some wonderful events to look forward to coming up in May. If you are looking to pursue your fellow of the American College of Healthcare Executives, the FACHE, some of us you see has the FACHE on our ribbons here. We are having a Board of Governors prep course. It's a 5-week virtual session. Our advancement committee is hosting that with faculty of trained HLNY fellows. And we're very excited because all proceeds for that BOG course will actually give back to the Foundation of the Healthcare Leaders of New York, which will help support scholarships for our healthcare leaders, which is fantastic. We have some wonderful upcoming events, 2 virtual programs in May, one hosted by our Diversity, Equity, and Inclusion Committee, looking at Black maternal outcomes. Also, an ambulatory care session that awards 1.5 virtual interactive credits. Very excited. One of our sponsors, Live On New York, we have a few Live On folks here, is actually hosting a tour that's open to all HLNY members of their Donate 8 Simulation Center. So if you're interested to learn more about organ donation, that's going to be a wonderful hands-on opportunity. We are definitely looking forward to, so save these dates upcoming later in the year, the 2026 annual gala and awards presentation. We are very excited to be awarding Dr. Katz our Award of Distinction award this year. Well deserved, as well as several scholarship winners as well. We have our beloved past president's boat cruise in July. Date is set, July 21st. And we do have our annual Better Together event in August as well. There are so many here to keep track of. So if you haven't already, sign up to subscribe to the calendar. You can go to our website and navigate to our events to subscribe to your own calendar. So as those become live, you'll have them. As I mentioned, the FACHE is something that we very much support all of you in. We have a committee designed to help support those who are interested to pursue the FACHE. Something to note is that there is a waiver period. This is something that I personally took advantage of last year and really got the gumption to pursue the FACHE last year. It is an annual waiver period. It has already started. It ends June 30. So if you're pretty close, sign into ache.org, see how many credits you've accumulated. Make sure to put in those applications before the 30th, because then you will have your BOG exam basically waived. You'll get $225 back. So highly recommend you do that. We all love a good deal. And if you have questions, email advancement@hlny.org. As I had mentioned, the BOG course is actually going to be supporting the foundation. The foundation is our charitable arm, our sister organization. Art Gianelli and Sharon Gianelli awarded the scholarship today to Michelle. Congratulations. There are other scholarships, Lineage Action. We have the Skanga family. Fred Skanga's here today in the audience. These scholarships are fantastic. We all could be benefactors to support the future of healthcare leadership, so you can scan that QR code to donate if you feel so compelled. But one thing I will note that's not on the slide, there's actually been a wonderful donation from Lee Perlman, who is one of our past presidents of HLNY as well. And it's actually setting up the HLNY membership fund, which is a fantastic way to help support any professionals who are in financial hardship and is a barrier for them participating in this organization and Healthcare Leaders of New York. So for students, early careerists, professionals in transition, if you're feeling any hardship to continue participating in this community, sign up to the foundation website and look for details about how to access that fund. That is closing. Please scan the QR code if you're not already following us. We do have a new TikTok, and we thank you so much. Everyone get home safe.
Nice to meet you. Thank you for doing this.
Oh, no, thank you. Sorry for being late. Yeah.
Thank you. Thanks, Gary.
Wonderful job, Dr. Katz. Fantastic.
Don't nice.
Excellent.
Brilliant. Chaos management, right? That's right. That's right. Awesome. Well done, gentlemen. Thank you so much. Absolutely. You really? That's nice. Okay, over here. Yeah, is that good? No, I think it's wonderful. Platform all right. Oh. Mine's good.